Hello, everyone, and welcome. In today's topic, we will talk about Behcets disease. Let's start with a clinical case, so you'll have an idea of how this condition works. A 30-year-old man with no known comorbidities presents to the emergency department with acute onset of severe, sudden chest pain accompanied by hemoptysis, but no signs of dyspnea. On initial examination, the vital signs showed little tachycardia and mild hypotension, with normal urine output and no fever. The blood work showed elevated C-reactive protein and mild leukocytosis, but no other significant modifications. The immediate differential diagnosis centers on pulmonary embolism. A computed tomography pulmonary angiography is performed, but instead of thrombus within the pulmonary arteries, the scan demonstrates a big saccular pulmonary arterial aneurysm, a vascular lesion with imminent risk of rupture. On further history, the patient reports a long-standing pattern of recurrent, painful oral aphthous ulcers, typically lasting over a week, as well as episodic scarring genital ulcers that he had never disclosed because he assumed they were unrelated. Retrospective questioning also reveals prior episodes of tender nodular skin lesions on the lower legs, suspicious for erythema nodosum. These symptoms combined point to a specific, unifying diagnosis: Behcets disease. Now that you know the bigger picture, let's dive into the details. Behcets disease is a type of autoimmune systemic vasculitis, which, in simple terms, means that the immune system mistakenly attacks and inflames blood vessels of all sizes, both arteries and veins, throughout the body. Although its exact cause remains uncertain, research suggests a combination of genetic susceptibility, particularly the HLA-B51 gene, environmental triggers, and immune system dysregulation. This illness typically follows a relapsing-remitting pattern, with periods of flare-ups alternating with quieter phases of remission. Now, let's focus on the clinical aspects of Behcets disease. The clinical features can be easily remembered with the everyday word apple. The first A is for aphthous ulcers, the painful, canker-like lesions inside the mouth. These recur multiple times a year, last more than a week, and are almost universal in Behcets disease. The first P stands for private area ulcers, in other words, genital ulcers. These are deeper, extremely painful, and often heal with scarring, unlike the ordinary oral aphthous many people experience. The second P refers to problems with the eyes. The hallmark here is uveitis, which is inflammation inside the eye. Both anterior and posterior uveitis may occur, and retinal vasculitis, inflammation of the retinal vessels, can cause sudden vision loss. L stands for lesions on the skin. These include erythema nodosum, which are painful red nodules usually found on the shins, and papulopustular eruptions that can mimic acne but are sterile. Finally, E is for everything else. This reminds us that Behcets disease is systemic. It can inflame large veins and arteries, leading to deep vein thrombosis, or pulmonary arterial aneurysms, which may rupture and cause fatal bleeding. It can involve the central nervous system, producing parenchymal disease in the brainstem or hemispheres that mimic stroke, or cerebral venous sinus thrombosis. It can inflame joints, usually causing a self-limited, non-erosive arthritis of the large joints. Some patients develop a positive pathergy reaction, which is an exaggerated skin response to minor trauma. Gastrointestinal involvement may mimic inflammatory bowel disease with abdominal pain and ulcerations. Now that we've reviewed the key clinical features of Behcets disease, let us move forward and consider how we approach its diagnosis and treatment. The diagnosis is essentially clinical. The international criteria for Behcets disease give the highest weight to oral, genital, and ocular lesions, while skin, vascular, and neurological findings add further points. A score of 4 or more classifies the disease. No blood test confirms Behcets, and although HLA-B51 may support suspicion, it is not diagnostic. Once the diagnosis is considered, treatment is guided by the organs involved and the severity of disease activity. In cases where the disease is limited to mucocutaneous, topical corticosteroids and systemic colchicine are often sufficient to control inflammation. When the eyes are threatened, particularly in situations of uveitis or retinal vasculitis, urgent therapy with systemic corticosteroids becomes essential, and this is typically combined with an immunosuppressive agent such as azathioprine to achieve durable control. For the most severe or refractory presentations, biologic agents such as infliximab can be highly effective in suppressing inflammation and preventing irreversible damage. Finally, management of vascular complications must be approached with caution. The use of anticoagulation remains controversial in this setting and should only be undertaken after carefully excluding the presence of aneurysms to avoid the risk of catastrophic bleeding. I hope this explanation has helped clarify this condition and made it easier to understand. If you found this video helpful, please like, comment, and subscribe for more medical content. Thank you for watching, and I'll see you in the next one.